बंद करता है कोई बीच में ऐसे लाइव स्ट्रीमिंग स्टार्ट होने के बाद? अरे यार एक बात बताओ, यहाँ काम शुरू हो गया है और मैं स्ट्रीमिंग बंद करूँगा क्या? है भाई, ये तो बता दो मुझे। यहाँ काम शुरू हो गया, मतलब इवेंट स्टार्ट हो गए यहाँ। अब बस आप अपना शुरू करो वहाँ पे, वो वीडियो स्ट्रीमिंग नेट पे लाइव करो। फोकस आउट है। लेवल फुल कर दो मेरे पास। हाँ, इवेंट स्टार्ट हो गया यहाँ पे। यूट्यूब पे लाइव शुरू हो गया आपका? वीडियो पे करते, लेकिन एक सिस्टम पे ना अलग से खोल दो आप, उसमें आप लाइव देख सकते हो यूट्यूब पे जाके। हाँ, और बुढ़ारा भी फ्रेम। पहले मैं 20 मिनट का डेमो दे चुका हूँ, पहले भी गुड आ रहा, अभी भी गुड आ रहा है ना, बस 2 मिनट में आ रहा तो ठीक ही आएगा। और अरविंद के बीच में कॉल कर देना ना। ओके सर भाई, बाय। स्टार्ट हो गई वीडियो का। बोल दी। स्टार्ट करें ना सर? स्टार्ट करें? हैं? कर दें? कर दें भाई? रेडी मैम? संजय जी बोल दीजिए स्टार्ट। मैम स्टार्ट। ऑडियो नहीं आ रही, ऑडियो नहीं आ रही भाई, ऑडियो नहीं आ रही। फुल करो ऑडियो। ऑडियो दो, ऑडियो दो।
Today, Dr. Keshav will be presenting the case of Master Daviz, an 18-year-old boy. And we have with us an audience full of enthusiastic postgraduates, senior residents, and also faculty members. On the panel today, we have Dr. Satinder Aneja, Director Professor, and Dr. Swasti Sharma, Assistant Professor, and I am Dr. Sharmala Banerjee, an Associate Professor. And we welcome you all, and we proceed. Dr. Keshav will start with the history.
और कम हो गया
Saves 8.5 years old age है from
नहीं आ रही है
date of birth being 23rd of December 2007. His chief complaints being difficulty in climbing stairs since past 1.5 years, difficulty in standing from sitting and recumbent position since past 1 year, and history of frequent falls since last 1 year. Patient was apparently normal 1.5 years back. When parents noticed that the child used to walk upstairs with difficulty, that is, used to
फोन आने लग जाएगा
hand over his knees and supporting it, and then used to climb the stairs. Also the parents noticed difficulty. Also noticed difficulty getting from recumbent as well as sitting position from last 1 year. Mother noticed that every time the child gets from recumbent or sitting position, he supports himself to one side and then he gets. Also notice that while getting up from sitting or squatting position, he keeps his hand over his knees for support and then gets up. Mother also noticed that child had frequent falls since last 1 year while walking. He found buckling of knees, which gradually is increasing in frequency since last 1 year. They don't give any history of pain in upper limb or lower limb. There's no history of any fever or rashes. There's no history of any difficulty in combing hair or lifting arm to reach objects which is kept above the racks or bringing food to mouth. There's no complaint of inability to mix food or wearing slip or buttoning shirts, wearing shirt, etc. There's no history of difficulty in wearing sandals or slipping. There's no history of feeling of any tightness in the limbs or bruises. There's no history of any abnormal movements or any obvious convulsions. There's no history of any loss of consciousness, any history of irrelevant speech or loss of memory. There's no history of any difficulty in speech. There's no history of inability to smell or any visual blurring or bumping into objects while walking. There's no history of any double vision or no history of any drooling of saliva, difficulty in chewing or sleeping with eyes open. There's no history of any obvious hearing difficulties. There's no history of nasal twang or nasal irritation of food, choking spells or difficulty in swallowing. There's no history of slurred speech. Parents didn't notice any rapid eyeball movements or abnormal movements in the eye. There's no history of any incontinence in urgent or dribbling.
ये आ रही है देखो ये
The patient doesn't get any history of trauma, any history of previous dog bite or snake bite. There's no history of any difficulty in breathing or even palpitations or swelling of legs.
हेलो हाँ ऑडियो मेरे यहाँ से पूछे पीछे से कम आ रही है उनको बोल दिया कि भैया ऑडियो चेंज करो भैया ऑक्स आउट
According to parents, since they noticed entire problem from last year, the problem of difficulty in climbing stairs as well as difficulty in getting up from squatting or recomposition has been same according to parents from last 1 year. But the history of fall, what they're saying, the frequency of fall has been increasing since last 1 year. Initially, the child used to fall once in a while, but nowadays the child is been falling repeatedly, and there's also history of some injuries because of fall.
फुल कर दो इसका फुल करना कुछ नहीं आ रहा दोनों
There's no history of
कुछ और पंगा है भाई
according to mother, there's no difficulty squatting or sitting.
अभी बड़ा था
After he squats or sits, there's always he keeps his hand over his knees and then gets up.
आया था अभी बड़ा था अभी बड़ा था अभी बड़ा था अभी बड़ा था भाई
There's no difficulty in
फुल हुआ था भी एकदम कुछ करा आपने
it doesn't
नहीं आ रही ऑडियो यार।
Yes, he doesn't have any problems in acting in school, and he plays with discipline as well as other children in school. And you can get on with it.
हेलो वो भैया मैंने बोला था उनको पीछे से देंगे ऑडियो तभी तो आएगा ना। मेरे यहाँ से फोटो खींच के भेज देता हूँ, मेरे यहाँ से तो लेवल फुल है,
Mother
पीछे से
says
नहीं आ
that
रहा।
nowadays the child while climbing stairs, mother asked him why you are keeping his
वो तो
hands
सर
over his
दिनेश
head.
जी ने
He
बोला
said
उनको
that
कि
I
लेवल
fall
बढ़ाएंगे,
back, so
क्यों नहीं
I'm
बढ़ा रहे वो
keeping my hands over his head. That's what mother is keeping his class.
फुल कर दो इनका भी। ऑडियो में आ रहा है, इनका नहीं आ रहा। और तेज कर दो।
क्रिकेट फुटबॉल इसमें की जो गेम्स है भाग दौड़ वाली, तो पहले जितनी करता था साल भर पहले उतनी अभी कर रहा है या कुछ आपको लग रहा है फर्क? बाकी बच्चों के मुकाबले, इसकी उम्र के बच्चों के मुकाबले उतना खेल पाता है या
कौन सी लगाऊं? कौन सी हरी काली कौन सी निकालूं?
पहले के मुकाबले खेल नहीं सकता बच्चा?
रुकना रुकना रुकना, एक सेकंड बोलने दो, एक सेकंड रुकना। रुक अब फुल आ रहा है यहाँ पे भी, फिर डाउन हो गया। इनके लिए माइक का नहीं आ रहा है जो बोल रहे
पाता होगा ना, जैसे नॉर्मली रस्सी टांगते हैं बच्चे को
नहीं आ रहा है कुछ लगा दी ये लो, ये लो। नहीं आ रही इनकी आ रही, अब आया अब आया, फिर चला गया, आ रहा है जा रहा है, आ रहा है जा रहा है, ऐसे हो रहा है। पता नहीं है आपके साथ आ रहा है जा रहा है, आ रहा है जा रहा है। मैं भी माइक लगाता हूँ अपना। नहीं आ रहा नहीं आ रहा, बोल रहे हैं वो आधा आ रहा है।
may not be what you are expecting or the limit outdoor activities. So this is the problem, because when you are going to follow up this child also, you would like to make up how long can you walk, what can you do. So that is important.
gait abnormalities, okay, and
नहीं आ रहा भाई, नहीं आ रहा। ऑक्स कहाँ लगाया, ऑक्स लगाओ ना।
and
वही कर सकते हैं एक, ये देख, लेफ्ट राइट दोनों बराबर आ रहे हैं। हाँ तो अपने आप आ रहा है, जा रहा है पीछे से, मैं क्या करूँगा? देखो गया आया। ये मैडम का माइक ठीक आ रहा है, बाकी किसी का माइक ठीक नहीं आ रहा। हाँ फिर चला गया, फिर छेड़ा, फिर चला गया।
System.
Locomotor system.
So the locomotor system. And anything else apart from that? So from the history.
Was around 7 years old when they started noticing the thing. But they used to, they didn't consult any healthcare facilities for that.
So
they thought it
the
was
onset
normal.
was apparently 7 years, at the age of 7.
7 years.
And over the last 1 year, there
1.5 years.
apparently is no progression. And from the symptoms, we believe it is the system of locomotor. Can you narrow it down further? He told a lot of other histories. What was the relevance of that? Why did you ask about the chappals falling off?
Ma'am, since there's a involvement of locomotor system, I wanted to relate whether it's involving muscle or not. So in this case, involvement of difficulty in wearing chappals or difficulty in eating food was mainly to relate any distal muscle weaknesses which can occur in locomotor problems.
And you also asked about whether he had a difficulty in reaching up. Why did you ask that?
Ma'am, reaching of objects which is upper requires proximal muscles of shoulder and upper limb. So to rule weakness of that area, I asked this history.
So specifically of getting up from recumbent or supine position, what do you think that is due to? Is it narrowing down it further?
It's a proximal muscle weakness.
Proximal muscle. Okay.
So from this history, what have you gathered about the involvement? Which are the areas in the body which are involved? The limbs, upper limbs and lower limbs, or only lower limbs?
Lower limbs.
Only lower limbs. And in the lower limbs, proximal or distal? Proximal. And you are certain that there is no upper limb involvement?
Ma'am, according to history, there's nothing suggestive that.
So you've asked about the proximal muscles, and have you asked, what did you ask to assess the function of the distal muscles of the upper limbs?
Since he goes to school, I asked whether he can write properly.
So there's not been any deterioration in the handwriting?
There's no difficulty in writing. He buttons the shirts, he can wear shirts, he can mix food, he can take food by himself. So these are the things I asked to rule out any problems in distal aspects of the upper limb.
अपने कपड़े खुद पहन लेता है, वो उतार लेता है, स्वेटर वगैरह खुद से ऊपर उतार लेता है खुद से. That can also be an indicator of proximal. सिर से खुद निकाल लेता है.
आपकी मदद बिल्कुल नहीं चाहिए होता है. वेरी गुड.
So why did you ask for the history of rash and fever?
Myositis, dermatomyositis, polymyositis may be associated with rash.
So the dermatomyositis can present, but it would not be, its onset probably seems insidious from what, like they're not really sure when it started, right?
And
So
most of the time it will be associated with pain.
pain.
But estimate pain.
Okay,
So that's a very big clue. It's a big clue that it's a locomotor problem, and we've defined the topography of the areas involved, and there is no pain. So how will that help us?
Myositis, there will not be no pain.
So it gives us a clue, right? It's leading to one direction. Why did you ask about snake bite?
Ma'am, actually, in this case, the history is quite long, 1 to 1.5 years. Otherwise, acute weakness can be a
So
cope.
that was
the intention, ma'am.
So it was a slip. So, but it's important, even you learn from mistakes, right? So the clinical phenotype is something which is insidious, which has been there for the last 1 year. If you had something which would have resulted from a snake bite, it would have been a acute, hyperacute event, right? So there's a ventilation perfusion mismatch between his history and the clinical phenotype of the child. So you must remember that you have various differential diagnoses for different entities: acute, subacute, chronic. And if your history is something of a chronic phenotype, then you will not ask negative histories for the differential diagnosis of something which is an acute or a hyperacute event.
Dog bite also similarly, like.
Should we have also asked for history of joint swellings and joint pains in this child?
There can be joint involvement in rheumatological, yes, that's important. Any other history which any of you thinks you need to have? Yes, good.
Sir, any history of drug intake, because steroid will induce steroid myopathy.
Very good.
And any history of EC fatigability, or any history of intolerance to cold, because hypothyroidism will cause this myopathy and difficulty in walking.
Yes, it is a treatable cause of
myopathy. Or features of suggestion of hypothyroidism, because hypothyroidism also will cause muscle wasting, muscle weakness. So,
which other endocrine causes can cause?
Hypothyroidism, rickets, or Cushing-White syndrome.
So these are all other important causes. It may not be primarily a muscle disease, but other systemic illnesses which can cause. Okay. So,
History of any cramps, or did the patient have any cramping pains? Nothing. I'm not sure. It's very difficult to get. Adults can give you these histories, but these are important for muscle problems. But I don't think this much of the age of a child may not give these histories.
Have we managed to localize the clinical phenotype completely? We know that the limbs, the lower limbs are involved. What are the negative histories which we need to ask, which you have asked, but it's kind of been interspersed with the etiological history also? You asked about chewing and swallowing. Why?
Again, ma'am, any involvement of bulbar muscles can cause difficulty in chewing and swallowing.
Okay. Why did you ask for double vision?
Involvement of extraocular muscles can cause double vision.
So the first step is to identify the clinical phenotype. After you identify the clinical phenotype, then you start asking the history towards the etiology for that particular clinical phenotype. You understand? Like what Keshav did was that he put in a few, he started off with the locomotor, then he started off with the proximal, the distal, and then in between he came up with a little bit of etiology. Then again he came back to the involvement of the extraocular muscles and the chewing. Then he went back to the etiology again. So it became a little confusing.
So what Shaguna is trying to say is, when you are presenting a history, it's a very good idea to make it more coherent and make it a logical conclusion, you know. To it should be more, okay? So I think we have done with the history, or shall we go ahead? We can move on, I think.
Past history, there's nothing significant past history. Birth history, annually.
What do you want to ask in the past history here?
Ma'am, past history, any similar complaints, whether it was a progressive disorder, otherwise any history of any, before onset there was any history of fever, or there was any history of acute illness, following that there was a progressive weakness. So I wanted to wrote these things.
I would like to ask about any previous surgeries, anesthesias.
Immunizations also.
Yeah, that is also important, because some of these disorders can have problems, you know, any
rhabdomyolysis associated with anesthesia in myopathy problems.
Malignant hyperthermia. So even these become very important. Sometimes these are the starting points of getting the diagnosis. So one should ask, how was he, if there was any previous hospitalizations. And they can also have hospitalization for respiratory if we have not examined the patient. So those things are important. So specifically you must ask this.
And yesterday we have to ask complication also.
Yes.
Complication like they will have respiratory problems and they will have cardiomyopathy. So we should ask about any cardiac failure problems.
Why did you ask about seizures?
Ma'am, any upper motor, any cerebral involvement in the weakness to wrote any, if it's not a peripheral involvement.
Okay. Birth is uneventful, normal.
Birth is not antenatally was uneventful. Perinatally he was a single term normal vaginal delivery, home-born child. Birth weight was not known. He cried immediately after birth.
Okay, Shiv, one sec. Is there something important which you need to tell us in the antenatal history? If you're thinking of whatever you're thinking.
Ma'am, any decreased perceivement of movements, history of oligohydramnios.
So decreased fetal movements, and before that the quickening. At what age, at how many months was the quickening perceived for the first time? That's also important. Okay.
He's a fourth in birth order with two elder siblings, and the second child got aborted at the second month of gestation. There's for treatment history, he has taken some herbal medications from a local practitioner for this same complaints for a period of about 2 to 3 weeks in last 3 months. Otherwise, he's not been on any permanent medication from last 1.5 years.
Is their family history complete?
Family history now.
You told us about the number of issues. What about consanguinity?
Ma'am, he was born of a non-consensual marriage, and in both as well in fathers as well as mothers relatives known. There's no similar complaints among the two generation of this family. Similar complaints among family members, and even siblings don't have any similar complaints.
There is no other affected family
members. Among elder siblings, one is male child and one is female, and both are healthy.
How old is the other brother?
Ma'am, elder brother is 12 years old and elder sister is 10-year-old. Coming to developmental history, gross motor, the child attained head control at the period of 3 to 4 months. He started sitting with support at the period of 5 to 6 months and without support by 8 months. He started walking by first year and started running by 1.5 to 2 years. He could climb stairs with 2 feet at a time by 2 years, and he could climb downstairs with 2 steps by 4 to 5 years. Currently, he can, according to parents, he can even ride a bicycle with the support. There's a 4-tired bicycle which he can ride on himself. Fine motor, according to development assessment, he can right now copy triangle as well as he can copy rhomboid, the last attained milestone.
But he's going to school, he must be writing.
He's going to school, and cognition wise he's studying first time, and according to parents he's failing studies, and he can even count up till 20.
But he's 8 and he's going to first standard, so that is not age appropriate. Yeah. What would be the 8 years old doing in the school? 8-year-old means he would be in class 3 or class 4. कौन से class में पढ़ता है ये? First में पढ़ता है.
Why is he going to class 1?
कौन से?
What about the speech? You didn't talk about speech. Language.
Language, ma'am, he can. He's able to say simple stories also to parents, and he explains whatever happens in school. He can according to mother, he explains explains the incidents to the mother. He can build up a conversation with the parents as well as with the relatives.
Just ask him how old he was when he entered school.
कौन सी इसमें कितने साल पहले स्कूल ज्वाइन किया इसने? अभी पहली कक्षा में पढ़ रहा है ना? 3 साल हो गया। LKG
क्यों छूट गया? ये टीचर ने देखते नहीं है कि किस क्लास के लायक है तभी डालते हैं, ऐसे तो नहीं करते वो।
ये पढ़ने में कमजोर भी नहीं है, ठीक है, जैसे पढ़ाई छोड़ देता है तो ये भूल जाता है।
अच्छा, लेकिन जैसे इसके बाकी जो क्लास में जो पढ़ते हैं वो कितने साल के हैं? छोटे ही होंगे ना थोड़े से। और वो भी 8 साल की है।
हाँ, 5 महीने बड़ी है।
अच्छा अच्छा अच्छा।
इस बाजार में जाता है तो सौदा लेने के लिए तो हिसाब किताब कर लेता है
जी।
हाँ
जी,
पूरा, जैसे कुछ सब्ट्रैक्शन माइनस वो करते हैं जो 20 रुपए 200 रुपए के सामान
ऐसे ही करता है। ये मुझे भी रखने को देता है ना तो वो पूरा हिसाब कर लेता है मुझसे। मेरे अब इतने बचे हैं तो इतने दो मुझे। अच्छा, ले लेते हैं पूरा जी। और फालतू ही ले लेते हैं।
Why we are asking this?
हिसाब तो इसे पूरा आता है, पूरा आता है इसे हिसाब।
बोलता साफ कब शुरू किया था? साफ बोलना साफ बोलता है, कोई बीच में अटकता
नहीं, अटकता नहीं है, बिल्कुल साफ बोलता है। कोई कविता सुना पाएगा ये? पोएम जी, पोएम ही सुबह से शर्मा।
अच्छा,
यहाँ पर आता है, माइक में सुनाएगा।
सुनाएगा।
मछली जल की रात बोल दे, आवाज आएगी। Is it important to ask about the clarity of speech? बोलो। Why?
Again, in this case, it is condition is proximal muscle movement, but again to road any muscular dystrophies which involves the facial weakness as well as bulbar muscle. Again, we have to rule out any difficulty in speech.
So the content of speech would indicate the cognition, and the clarity of speech would indicate the neuromuscular coordination. Okay.
Socioeconomic history. They live in a pakka house in a joint family of 12 members. Father is educated till 7th standard and mother till 8th standard. Father has his own business and he has around.
Anything significant?
Nothing.
So let's proceed with the examination.
Yes, on examination.
Can you demonstrate it on the test?
Yeah, sure. On examination, the child is sitting comfortably on chair. He looks alert and conscious. He is conscious. Vitals, heart rate was 96 per minute and regular rhythm, good volume, normal in character, no radioradial or no radiofemoral delay. Respiratory rate was 16 per minute and it was thoracoabdominal with no paroxysmal breathing. BP was 94/60 mm mercury. It was a 50th percentile for his age. General physical examination. Child is pale. He doesn't have any case clubbing, cyanosis or lymphnopathy. Head-to-toe examination. The child has multiple scar marks over his forehead, with the parents attributed to the frequent falls he is having from last 1 year. His skull appears normal. There is no obvious deviation of any eyeballs or any deviation of mouth. There is no obvious scoliosis. The abdomen is protruded and the child which has exaggerated lordosis.
इसके जो ये जख्मे हैं ये अभी पिछले साल ही लगे हैं? ये माथे पे या
ये बचपन में गिरता था, ये चलना
बचपन से गिरता था
जी।
तो लगभग किस उम्र से गिरता था?
ऐसी 1-2 साल के बाद ये गिरने लगा था
दिस इज इम्पोर्टेंट
जी।
1-2 साल के बाद गिरने लगा था, फिर बीच में कुछ लगा कि फिर क्या हुआ?
नहीं, फिर ऐसा हुआ जैसे ये 3 साल का था, ये जब गिर जाता था फिर चोट लग जाती थी, फिर 8-10 दिन के बाद फिर गिर जाता था, ऐसे ही खेलते खेलते ही गिर जाता था।
तो आपके तो और भी बच्चे हैं
जी।
उनके मुताबिक ज्यादा गिरता है ये या
नहीं, बस यही गिरा है,
यही गिरा है?
जी।
वो लोग भी उस उम्र में नहीं गिरे
नहीं।
हैं?
वो नॉर्मल है।
इसको यहाँ पे ले आओ।
So see, this onset was early, like she's saying now 3 years to 2 to 3 years he had started falling, and in between they probably were not very concerned about it, and now they're now again concerned. Now the falls have increased for the last 1 year. Why do you think this has happened? This child was falling at about 3 years, but they were not really concerned, and in between he seemed to be fine, and now for 1 year he's been falling. So is there any explanation for this? What is happening?
Sorry. Can you just all of you notice what's happening over here?
Yeah.
भैया थोड़ा सा आप बैठोगे? इसमें आप ये कराओगे? What did you see over here? Why is it important? Sorry, but this was a typical video movement.
But yeah.
दोबारा
चलो पहन लो, वेरी गुड, पहन लो. Okay, but what's happening here? What do you observe?
Was it normal? Does he have normal? Is he doing it normally? इधर आ जाओ, शहबाज आ जाओ, आ जाओ, आ जाओ.
अरे वाह, तू तो बिल्कुल सलमान खान लग रहा है. आजा दिखा दे.
इधर 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 खड़े हो जाओ. हाँ, उतारो अपनी, खुद से उतारो, खुद से उतारो.
खुद से उतारने दो. Because now you can figure out why there's a discrepancy with what she is saying and what he is doing. उतार दे, उतार दे, जल्दी से उतार दे.
फटाफट देखिए कितनी जल्दी उतार सकते हो. उतारो, उतारो, उतारो. I won't do it.
चलो तो यहीं उतार दो।
Okay. We'll give it a break and then.
But do you observe? What do you observe? So he's adapted himself.
He did a lot of trick movements and with more of a distal movements he's able to take it out. Okay, if you see him now, his abductors are not very strong.
He's
shoulder
bringing his head
abductors
down.
and flexors. Yeah. Actually, yeah. And he probably needs help. Okay.
नहीं, इसका गला भी छोटा
घर पे आप कराते हो, खुद करता है?
नहीं, खुद कर लेता है।
फिर समय लगाता है?
जी।
समय थोड़ा फंस जाता है कभी कभी. गर्दन छोटी हो, ड्रेस की कुछ में तो प्रॉब्लम हो जाता
इसका
है.
भी गला छोटा है,
इसका भी गला छोटा.
ऐसा खुद कर लेता है ये।
So did you see? हाँ. अभी वहाँ अब उतरी रहने दे 5 मिनट बस. ठीक है. So okay. हाँ बता. So what I was trying to tell you was that in Duchenne muscular dystrophy, this typically symptoms, the children walk a little late, but after that the parents start noticing falls by about 2.5-3 years of age. After that, as the normal growth and development proceeds, the child seems to improve, and there is something called a honeymoon phase, and they seem to keep improving by about 6 to 7 years of age, and then as the degenerative processes start and worsen, they start having falls. So these maybe we have not gone. He should have gone in the early part of the history also, like I think Madam asked, and that history came up. Like there were falls earlier, and in between, child seemed to be fine, and now they're again developing these symptoms. So the onset usually is early, before 5 years of age.
What I want to tell you all is that once you saw these scar marks, that is the time you have to clarify it again. So you have to go back and say how did he get it? So since when is he getting it? That would have told you the whole history. Okay? So when you see something, go back again. Try to get clarifications again. So just now we got that information which we should have brought out right in the beginning.
अच्छा, आप भी आ जाओ. ठीक. So what all do you see?
These the scar marks of the forehead.
Okay.
And
नहीं, let him stand. इसे दिखा दें. So you can see the prominent lumbar lordosis. And there's
because of exacerbate lumbar lordosis.
and come वापस आ जाओ वापस आ जाओ वापस आ जाओ वापस आ जाओ
इसकी चाल चाल पे
गेट ठीक है मैं कैन डू इधर इधर आओ इधर आओ इधर आओ इधर आओ इधर आ जाओ
हेलो
अच्छा माइक ले लो आ जाओ आ जाओ तुम भी ले लो एक माइक आ जाओ आ जाओ आ जाओ आ जाओ आ जाओ शाबाश 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 so you notice which all muscles are hypertrophied calf okay and you notice his gait also while he's walking he's
So what is the gait?
what is it
Waddling.
waddling
And where is he putting his feet first?
toes
Normal should be heels.
heels okay so he has a toe strike okay and this waddling gait and lumbar lordosis prominently to be noticed and what all muscles are hypertrophied calves okay
Demonstrate single valley sign where
one sec sorry when we're talking about the gait when you're asking a child with a neuromuscular disorder you also have to ask them one to walk properly walk normally also if a child is capable whether he can walk on his tiptoes and if he is capable of that if he can walk on his heels as well so have you asked him to do that ask him let's see if he can do it you have to demonstrate to him make it a fun challenge very good shabash
अब हील्स पे ज्यादा मुश्किल लगा बट एनीवे
हील नहीं
डेमोन्स्ट्रेट करके दिखा उसको
अभी देखो सारे
एडियों पे चढ़ो
ऐसे चलना ठीक है ऐसे और ऊपर
नहीं बट ही इज ब्रिंगिंग इट डाउन मतलब कर रहे हैं
so do you notice that toe walking was much easier for him as compared to the heel walking
What is the significance of that, Keshav?
since there is a weakness in hip girdle, the child is trying to balance himself by bringing to alignment. So that is the exact process as well as toe walking will help in maintaining the balance.
Can anybody expand on that? Why do we test for both the toe walking as well as the heel walking? Third years? There are different compartments, different muscle groups. So which group are you going to assess in which type of gait? Swasni, आप भी बता दो इनको.
Toe walking we are assessing the gastrosoleus compartments.
yes so plantar flexors basically and the heel walking is for the dorsiflexor muscles okay in some these sometimes help to differentiate between various type of dystrophies muscle dystrophies in some usually most of them will have plantar flexors are the strongest muscles they remain strong till the end but rarely in some limb girdle muscular dystrophies there may be the dorsiflexor weakness earlier the plantar flexor weakness earlier that's a rare situation but most of the times these are strong muscles and patients may present with toe walking as the first symptom they do present with that okay so just wanted to show the muscles which are hypertrophied you can see it's not just the calves which are hypertrophied but deltoid biceps brachioradialis okay quadriceps and even tongue is sometimes enlarged though not in this patient and there is a interesting sign called the valley sign which focus hai bachche pe how do you demonstrate the valley sign
The child is asked to affect his arm at 90 degree and elbows to be flexed at 90 degree. And in this case, we can see two muscle bellies being enlarged. One is the infraspinatus muscle and the posterior belly of posterior aspect of the deltoid muscle. And because there is a hypertrophy of these two muscles, and between there is a atrophy of this axillary fold, there is something called valley which is formed here. So it's called valley sign. Here we can see infraspinatus being hypertrophy and there is a posterior belly of deltoid being hypertrophy and there is a formation of valley which is
so what is the importance of this valley It's supposed to be specific for dystrophin-related disorders like Duchenne muscular dystrophy. Many other muscular dystrophies may have hypertrophy muscles, but this valley sign is more predominantly seen in Duchenne muscular dystrophy. That is why it's important.
Okay. Why do you have hypertrophy in these areas in the first place?
Because of position of fat and connective tissues, which occurs in some of the muscles, which involves calf muscles, tongue, as well as in upper limb, infraspinatus, deltoid, as well as brachioradialis. So in these muscles there is a deposition of fat. So it's called pseudohypertrophy. It's not actual.
Yes, somebody was asking about gastrointestinal disturbances from one of the other centers. Usually smooth muscles are spared. It's a skeletal muscle, and cardiomyopathy can occur, but smooth muscles and even the sphincteric muscles, levator ani, these are spared. These muscles are not involved in muscular dystrophies usually. Okay, acha beta acha. So
The way you have maneuvers we demonstrated maneuvers for the lower limb. Are there any maneuvers which you would like to demonstrate apart from this for the upper limb? Anything else? हाँ अभी तो पूरा बाकी कर रहा हूँ.
So was Gauss sign positive?
Yes, ma'am, it's positive.
Okay, can you इसको नीचे बैठेगा. So Gauss can be done. Usually we do it sit to stand, but there's the typical book method described as supine to stand. So that will take an even longer time. This might be difficult in this child to make him supine here, but we'll do a sit to stand Gauss. बैठो बेटा. बैठो. हाँ अब खड़े हो जाओ. खड़े हो जाओ. नहीं इसको नहीं पकड़ना. इसको नहीं पकड़ना. So don't let him hold anything. खड़े हो जाओ. बस देखना चाहते हैं कि कैसे खड़े हो रहे हो. So you can see he raises his buttocks up first, and then he takes support of his, he literally climbs on himself. Okay. This is basically showing the proximal muscle weakness. It's not just a Duchenne child who will have, but any muscle problem that causes proximal muscle weakness would lead to a positive Gauss sign. Okay. So for upper limbs, ma'am was asking any specific other maneuvers for upper limbs? Any for shoulder weakness, scapular weakness? Can you do something?
Manual muscle testing.
Well, that we'll do, but but you can. So you have this, Sangeeta. So yeah, you can look for winging of scapula by
ask the patient to
push against the wall and do it. Okay. Now again, scapular weakness is not very prominent in Duchenne muscular, but it is prominent in some of the others. So these are important, useful. They will give you clinical clues of what is going on. Like we can see there is no extraocular muscle involvement, there is no facial involvement, there is no bulbar involvement. It's a limb involvement predominantly, right? So can you just show the muscle testing?
Yes, ma'am.
Okay. Cranial.
Which cranial nerve is very important to check for the cranial nerves which you really have to check for in this kind of a child? I mean the maneuver. How are you going to test the extraocular muscles?
Extraocular muscles will ask to.
करके दिखाओ.
इसको बैठा देते हैं. बैठा दो. Cranial nerves and muscle testing. Cranial nerves, extraocular muscles, facial blowing. Extraocular muscles.
You'll have to come to the side.
Come on the side so that you can see the camera.
I think उस तरफ खड़े हो. अब केशव उस तरफ because the camera is this side.
Now what are you testing? Which muscle, which side? Of which side? You test them together like this? Would anyone else like to show? Surya? No? So, Ramya? Usually it is tested separately because एक काम को बंद करो और नहीं बंद करने की जरूरत basically you test, first you test the medial and lateral rectors by asking the abduction and adduction and then in the abducted eye, you first make the patient abduct the eye and ask him to elevate and depress. By elevating the abducted eye, you are checking for the superior rectus, and making him depress, you check for the inferior rectus. And in the adducted eye, when you do these movements, you are checking for the obliques. Inferior oblique will cause elevation in the adducted eye, and superior rectus will cause superior oblique will cause depression in the adducted. So you don't test, you are testing in the midline gaze, and that you will not be able to test anything. Okay, so that is important. What about facial?
Facial, first one is frontalis. Frontalis by asking the patient to frown. We can ask the patient if he is understanding to frown by himself. Otherwise, we can just ask to see the. अब इधर देखो ऊपर देख गर्दन ऐसे we can see there's no difference in if head. He can frown and it's bilateral. It's equal. Equal. Ask him to close his eyes and we should try to open against resistance.
बिल्कुल कस के बंद करो, खोलने मत दो.
We can ask him to blow air by and we can ask how we should see how easily it can be.
You can ask him to show his teeth. Okay, so different facial muscles are tested. Look for the nasolabial folds on both sides, they're symmetrical. So there's no facial weakness. So we start with the limb testing or muscle testing. Limb testing.
Can we just before we start the limb testing, all these maneuvers also have another purpose, and that is timed activities. So your Gower's sign, your blowing, the way he's walking. If he's come to you today, make it into a game and tell him that and time it. He's doing it today, suppose walking that much distance in 40 seconds. And he comes back to you after 3 months. And at that time you see that he is taking around 60 seconds. Or you ask him, you time him and you say that okay, in 10 seconds, let's see how many times you can blow. So you can make these into games, and by this you can actually see how much progression is being made over time, which as we saw here, like parents do not appreciate these things. The subtle ones can be done like that. Okay?
Location and response to treatment. Yeah, because we do have treatments, it's not untreatable. Okay. Yeah. Okay. Limb testing, yeah.
In sitting position, I want to first look for shoulder abductors.
So basically what he's saying is that we do test all joint-wise various muscle groups, but it is better to test whatever is possible in one position before moving the child to another position. So in sitting position, we can test many muscle groups, most of them in fact. Then we make the patient supine, and then side lying position, both ways, and prone position. Okay, rather than suppose you want to test his hip, and then you hip flexors, you first make the patient say supine, and then for abductors you make him side lying, then you make him prone. So rather than turning the patient multiple times during one examination, you test whatever muscle groups are possible in one position and then change the positions. That is what Keshav is saying. So we will first demonstrate in the sitting position what all he is testing.
First I want to demonstrate shoulder abductors without any resistance, and whether he can abduct against the gravity.
You are coming in between the camera and the audience. So you have to demonstrate to them.
In this case, child can abduct against the gravity. So I want to give resistance to this movement and check whether he can
fix the joint proximally. Okay, so yeah. You see, he's testing shoulder abductors, he said, but he has not fixed the joint because he was using trick movements. Okay?
He is using you, and you haven't actually. You can't see his spine. We can see the spine. He's twisting his spine a bit, so he's using compensatory mechanisms. So you have to keep an eye open for that. Don't look at just the end result. See how the end result is getting achieved.
Fix the joint. So And a basic principle of testing is you need to fix the joint proximally, okay? And then make him do. You can test one at a time. You don't need to test both. So test just maybe the left side. So he was able to do against. Was he able to do against gravity?
He can do against the gravity, and he can do with some resistance, not the maximum resistance. With some resistance, he can abduct his shoulders.
Okay, resistance he's doing, but not for full range against resistance. Okay, so what is the power?
4 minus. He can do with minimal resistance.
Minimal, okay. So I'm doing the wanting no minus and plus.
No, that is
So
stick to the usual traditional MRC.
MRC.
Minus plus.
Because there's a lot of confusion. Now I'll go against resistance. Up karo. So he's not able to. This is for the knee extensors. I'll fix the knee and ask him to extend the knee. Up karo. So again he's not able. Fine. And ankle dorsiflexors, you can ask him to dorsiflex the ankle. Upar karo. Upar karo try. So he is able to do. So ankle dorsiflexors are over. Ab later beta. In the supine position, there is one very important group of muscle which we need to test, which is that neck flexors. So there is a very important group of muscles which need to be tested in the supine position, which is neck flexors. Okay, so we just ask the patient to lift his head up when he is supine. Beta sir उठाओ अपना ऊपर ऊपर उठो ऊपर उठो. So is he able to do it? Yeah. So not against, he's not able to do against gravity. So most of these neck flexors are the earliest muscle to get involved in DMD. So if we go back to the history and ask the mother and how he gets up when he's supine, she'll tell that always he will roll on one side and then get up. We're not testing all the group muscles, but these are the chief muscles which are to be tested. So for the hip abductors, again like he's doing, you fix the hip and ask the patient to raise this leg, the leg on top. Okay, so is it at least 3/5? It is 3/5, and then when he applies resistance, you can see whether he's doing it against resistance or not. And how do you test for the adductors? Okay, so in the same position, he'll be holding this, he'll be supporting the limb on top and ask the patient to lift the limb below up like this. Okay, इसको थोड़ा सा ऊपर उठाएगा बेटा. See that later. It's difficult because adductors are usually also weak. So this is how you test, okay, and not in the supine position, because in that you're eliminating the gravity. Okay. So this is how you test and you apply resistance. Finally, in the prone position, you can check for the neck extensors. Ulta later, beta. Neck extensors when you ask the patient to. Sir, utha le apne beta. Sir, aise utha le. So this you can see he is doing it very easily. And neck flexors was very difficult for him. And back extensors when you ask him to lift up, and the hip extensors and the knee flexors. Okay, for hip extensors you have to support the hip joint, and for the knee extensors you will support here and then ask him to lift up. Okay, what is left is plantar flexors, which I think ma'am has already told you. When you ask him to toe walk, the plantar flexors are tested like that, and scapular winking that you see. Okay, so this is a rough, quick method of testing the chief muscle groups.
What is important? Two things are important: the position of the child and stabilizing the joint. Okay, these are the things, and mostly people make mistakes there. Okay, so I think, yeah. छोड़ दो बाकी, ठीक है. Time is already short.
So reflexes you tested.
Biceps was just elicited, but it's not normal. It wasn't normal. Triceps was not elicited, and brachioradius was also could not be elicited. Knee, it was again just elicited, but it was not normal. But ankle reflex was normal among different reflexes.
They usually reflexes should be preserved according to the strength of the muscle. They may, in the end, when the muscles become very weak, you may not get reflexes, but usually reflexes are preserved, and ankle is preserved till the end usually. And okay, sensory testing is normal. Okay.
Touch and pain was normal.
Contractures.
No, there's no contracture as of now.
Spine.
Spine, just for scoliosis, there's no obvious scoliosis, and but there's a lumbar lordosis which is exaggerated.
Contractures have started. You can see he's not able. You should be able to dorsiflex much beyond this. He has this. It's not going beyond 90 degrees. So he has this TA tightness, which is
It's important to look for the range of motion at all the joints. Then you'll be able to pick up the.
So these are the earliest contractures to develop. Then you have this iliotibial band, so there can be flexion deformity at the hip. Those are later ones, but this is this is the age by the time they start appearing. This 8 years.
Cardiac examination.
Cardiac evaluation was on inspection. Episode was at 5th intercostal space at mid-clavicular line. There was no any visible pulsations or any parasternal. On palpation, these inspected findings were confirmed. Auscultation, both S1 and S2 were present, and there were no audible murmurs. Cardiac examination was within normal limits.
What is your diagnosis?
Ma'am, he's a 8.5-year-old male child with predominantly proximal muscle weakness with the associated Gowers and positive with the calf hypertrophy, and there's also weakness in various muscle groups. So possibility of a myopathy, which is mainly proximal, and which is probably considering the age group of the child, I want to keep a diagnosis of Duchenne's muscular dystrophy.
So when you are summarizing before you come to the salient examination points, the salient history also, right? You miss the history. So you summarize salient history, salient findings, the salient negative history and findings, then your differential, that is fine.
So you are approximate, what is Duchenne's muscular?
Duchenne muscular dystrophy. Okay.
What would it be Duchenne's?
Ma'am, reflexes in case of Duchenne's at the initial period of this illness, reflexes are present, but as the disease progresses, the reflexes can be absent.
It's not progressed so much actually. Should come, maybe with reinforcement it may come. So
You
yeah.
might not have tried. Should not
Yeah.
have. So if it is absent, what does it signify?
Again, we should revisit the diagnosis.
Yeah, they need to think for a neuropathy or something, which is unlike, yeah.
What is the differential diagnosis?
A differential diagnosis.
Although the commonest is you have told us the commonest, right? But you want to keep any differential diagnosis besides anything else which could appear like this with hypertrophy and might masquerade.
With hypertrophy,
Very not common things.
Any other disorder, which suppose
Myotonic
it's not DMD, what else can it be?
But what else can it be? What other disorders can present with hypertrophy,
Weakness.
Theoretically,
myotonia congenita.
myotonia congenita.
Myotonia congenita, hypertrophy, yes, but they don't have so much weakness. He has significant weakness, है ना? Okay, hypothyroidism, the Cocker-Debray
Cocker-Debray syndrome.
Okay. So what is his height? Height come here. She has got short stature, no? Okay.
Exemption is
He's less than 3rd percentile. He is 89% of median.
He looks quite short.
But his BMI and weight is normal with normal, but height-wise, he's less than 3rd percentile.
So anything which causes short stature and causes muscle problems.
Vitamin D. This is thyroid, hypothyroidism, thyroidism.
Yeah, thyroid can cause. Okay.
Should.
What are the other causes of hypertrophied muscles?
Hypertrophied muscles. and weakness. And suppose that areflexia was there. Can you think of a disorder which explains?
Yes, anybody? Not very common, and maybe the age is also not very typical.
But they can present like this. Neurogenic causes, which neurogenic causes can cause proximal weakness and calf hypertrophy?
One, sir.
You can have SMA type 3, it can present like this.
SMA type 3 hypertrophy, ma'am, is it?
Yes, you can have hypertrophy.
Even Pompe's can have
acid maltase
and
Pompe's, they can also have hypertrophy. Having said that, this is the commonest one.
Yeah, you should, that is much
the
higher.
First one higher, but then you have to know of the other causes also.
What about limb girdle muscular dystrophy? Nobody is mentioning that. That is the next most common after DMD. So which ones can look just like DMD? And so you should at least know there's a term called limb girdle muscular dystrophy.
This is also a type of limb girdle only. It is involving the similar.
Scapuloperoneal.
Only thing is this is X-linked and those are autosomal. That is, they look quite similar to DMD. Okay, so you should at least know the differential. That suppose this patient doesn't have DMD, what else can it be?
So it doesn't. So it is not the end of the road. So there could be other causes, although this is the commonest one, no doubt about it. So let us presume that
this is okay.
This is the most likely diagnosis. So how would you proceed further?
Investigations. Okay, Bhavna.
We don't know that.
We don't know. In this case, we don't know. There's no history. There's no other person involved in the whole family. It's the only child who's affected.
Pardon?
He's saying DMD is less likely because family.
So does all brothers have to have
affected? Yeah. So 30% of the patients with mutations occurring for the first time. Okay. So when no family.
It is X-linked means who all is affected?
Males will be affected, but will every male, even if the mother is a carrier, will every boy be affected?
Will every boy be affected?
It's X-linked recessive.
So does it exclude or doesn't exclude?
50% of the boys will be affected, 50% will be normal, even if the mother is a carrier. Okay, and this, since there's no other family history in this patient, we should assume it's a new mutation. Okay, but how will you investigate this patient?
One by one.
Okay. CPK, okay. So CPK will be?
CPK will be very elevated.
Quite elevated, okay.
More than 15,000.
Okay. Not 15, but thousands. It will be in thousands, okay.
Then specific test like DMD gene mutation and muscle biopsy, EMG.
You will do everything?
Nice. Agar any family history is there, even screening test is creatine kinase itself enough to diagnose DMD. Agar if no family history.
No, still you would do. Suppose even that, okay, if the index person has a genetic testing done, fine. Otherwise you would still go ahead. Even if the family history is there, you need to have a definitive diagnosis.
If the elder brother was affected and he had been tested, then is a different matter.
Otherwise you still need to test, right?
Any index case has to be tested properly to make a confirm your diagnosis. Okay.
So how will EMG help?
So EMG we can rule out neuropathies.
But clinically, you know, it's a muscle disorder and suppose CPK is elevated, will you still think of neuropathy? So you don't need an EMG basically, that is the point. So don't, this is an important thing to know. Clinically, you know it's a muscle disease, you've seen, CPK is elevated, you know it's EMG will not add anything to it.
EMG is an invasive test.
It's painful.
Okay. So we shouldn't do it just for the heck of just confirming that when you have other methods which are less invasive. Okay.
So when would you do a muscle biopsy? Somebody mentioned muscle biopsy.
Ma'am, if you are really suspecting the clinical symptoms are consistent with the diagnosis of DMD and the CPK levels are normal, and also the dystrophin gene which we test via the PCR is normal, then we should go for the muscle biopsy. And also in muscle biopsy, by seeing the various things like carboxy terminus and amino terminus, we can prognosticate the patients with mutations in the carboxy terminus of the dystrophin gene, they have worse prognosis than the normal patient. So in those cases, if CPK level normal and the dystrophin gene in the PCR is normal, then we should consider for muscle biopsy. And also to exclude
not CPK. If CPK is normal, first rethink your diagnosis. Before going with the biopsy, because I have seen a patient, like one of the differentials you mentioned, they went to biopsy and biopsy was also normal. It was a myotonia congenita.
Okay.
So it will look like, so CPK is normal is not, we are talking of, you will consider it if the CPK is the same phenotype with high CPK, but you're not getting any positive genetic testing, okay, which will be present 30% of the patients, you may not get the common deletions. So, but even for now, you have MLPA assays and all, you have gene sequencing. So you can do away with the muscle biopsy. Only thing it's a little expensive to get all those tests done. So
muscle biopsy again, not in all cases, very, very selected cases. That too, if all these facilities are not there.
Yeah.
Otherwise, gene sequencing would answer most of your questions. Okay.
What will you see in the muscle biopsy if you do get it done?
High tissue infiltration.
That's not what we want to see.
how will that help to know whether it's limb-girdle muscular dystrophy or Duchenne? Does it help your differential diagnosis question? How will that help?
If you do a muscle biopsy, what would you do it for?
We look for dystrophin staining
So you need to do immunohistochemistry. That is, you should send it to a lab where the facility of immunohistochemistry is available. No point just doing biopsy, and it should never be sent in formalin. That is, I think, another important thing which you should know. Okay. So other investigations? Anything else? Anjali wants to say something?
ECG,
echocardiography and ECG.
ECG
Very,
echo.
very important. Okay. What will the ECG show?
Cardiomyopathy features.
So what typical features? Typically you should look for increased RS ratio in the lead V1 and Q waves in V5, V6. So this is an early finding of a cardiomyopathy in the ECG. Okay. And echocardiography also must be done at baseline and at least yearly or too early. It's important. Okay.
And if the child has cognitive impairment, then you get formal psychometric assessments as well.
Yes. And if facilities are available, probably every child should have, because they are common
this is very
comorbidities.
common comorbidity.
Yeah.
Yes, very good. So, baseline pulmonary function, especially because finally, I mean, it's the lung functions which are the most problematic, and that is very, very important. So we are not actually, the time is too short, I think, to go in for the long-term management and monitoring. Do we have time for all that?
It's already 5:40. Anything, maybe briefly treatment?
Yeah, treatment I think would be the first thing before we go on to the long-term.
Genetic counseling.
Yeah, I think two things are important for your exam. One is what is the treatment and what is the counseling of the parents. So what is the current treatment? What would you like to give to this child? What hopes do you have for the parents?
Physiotherapy and steroid.
Pardon?
Physiotherapy and steroids.
Steroids. Okay. Physiotherapy, yes, of course, supportive all, but steroids, yeah. So how?
What is the evidence? Do you think it is evidence? What is the evidence currently for steroids?
Steroid temporarily will stop the progression for 1 to 2 years, then it will not help that much. Ultimately, it will progress.
They can prolong ambulation by about 3 years, yeah.
And evidence is strong to give steroids, and we must give steroids, and there's definite, I think Cochrane and everything is supporting the use of steroids in.
But how do you give it exactly?
Yeah.
Once a month, first 10 days we have to give.
No. You have to give daily.
Current recommendation is daily.
Daily treatment, and you need to continue 0.75 milligram per kilogram per day. But when the child becomes a non-ambulatory, or if he's developing side effects, you reduce the doses. Earlier, the recommendation was that you stop when he becomes non-ambulatory, but now what they say is that you continue because it improves the upper limb function and respiratory function. So you bring down the dose to 0.3. 0.5, 0.2, gradually reduce the doses, but the daily doses need to be given, not intermittent.
There is no, I mean, there's a firm evidence on this that you have to give 0.75 milligram per kilogram if the child is tolerate, when the child is ambulatory, and as she said, reduces. So we don't do the other regimens were tried, but the evidence supports the daily dose. Okay?
Okay, so.
And genetic counseling? How are you going to talk to the parents? I think.
What are the recurrence risks?
आप
चले जाओ. Okay. अब बाहर बैठ जाना, बता देंगे आपको भी ना. Okay.
That is the most important thing. As a
Yeah.
pediatrician, I think clearly besides the treatment immediately, genetic counseling is most important.
So does she have a risk of having another child? There's no family history. You've seen that.
We can screen parents' carrier for carrier state.
Okay.
Then based on mother,
CPK level.
based on that we can genetic counseling we can do.
Okay, the mother is a carrier. Suppose she is not a carrier. Suppose it's a new mutation. Then is there a risk? Would you tell them to get prenatal testing in the pregnancy?
Prenatal testing we have to do.
Why? Suppose the mother is prenatal testing is an invasive process, no? So we advise them the mother is you've done a carrier testing. It's not easily available that MLPA of the mother. But suppose you've done it, and if it is she doesn't turn out to be a carrier, then is there a risk? A little difficult. There is still a risk. There is something called a germline mosaicism. The mother, there is about we say 7 to 10% increased risk in the next offspring, even if there is no family history, even if the mother is not a carrier by genetic testing. So prenatal testing is to be done even if the mother is not a carrier. That is basically we need to tell them that if she gets pregnant again, she should definitely come and report, and she needs to be tested. That's important. They need, it can happen, and as doctors, it's our job to not let another child with DMD be born.
It's not easy because we have seen recurrence in the same families, so I think this is very, very important.
That's important. Okay. Yeah. So carrier testing is, and you might need to test the sister also if
that she will also be a carrier.
She could be like that is so important. It's important to test the
for the family
testing.
Next generation. I think they are telling us to wind up, so we should.
We should wind up.
Yeah. So
any questions? We can
any other questions? We can take it after this session. Any questions?
तो बंद भी हो गया.
No.
If the mother is not a carrier, then
of course
then she won't be.
She won't be a carrier. We have, that's right. Any other questions? If no questions, I think I will thank all of you for being a nice audience. And we have not had any money.
We do send them for physiotherapy.
Occupational therapy would make things very, very simple. You have to make life easier for the parents with whatever disability they have. So a person can, if she has problem in combing, you can have some different ways, keeping the food table closer by if you can't lift. So that there are many appliances, then having orthosis, so that the night splints, prevent contractures. There are plenty of things which the physiotherapist and occupational therapist do. Both.
Occupational therapy is very important, as ma'am is saying. Physiotherapy should not be very intensive.
Yeah, it's not that we want them to exercise, and exercise has to be only as per this thing. But you don't then ask them to run around marathons and all. But the question is not only that; it's prevention of contractures.
The basic idea is to maintain the range of motion so that you prevent the development of contractures.
Much of strength training will not be possible, but contractures. Building muscles.
I think we'll stop here. Thank you very much. Thanks a lot.
हाँ